And is my screen up now?
Yes.
Okay, so let's go through GI mock orals. I think we have a break after this. I will try to stay relatively on schedule, though. I do have a hard stop for the Liverpool-Manchester City game. So either put questions in the chat or we should have a couple minutes at the end to discuss. Like the rest of your presenters, I also have my email address in there. Please feel free to reach out. GI, just a couple editorial comments. My sense is, at least for my examinees, people were relatively comfortable with this area. When it's a subject area where you're not necessarily dealing with, just kind of weird or unknown things, I like to probe a little bit on some of the gray areas. So areas where there's not necessarily a right or wrong answer. I'm just trying to get a sense for what you do when you're presented with ambiguity, and kind of can you work your way through that, largely without doing anything sort of unsafe. So the first case was a 65-year-old woman who presented with fairly typical symptoms for an anal rectal cancer. I did ask some simple anatomy questions and presented the following figure. And again, there are different ways you can look at this, right? You've got your embryological anal canal, which is, some people gave me that, and they indicated the dentate line as the boundary there. I would be familiar with the fact that the surgical anal canal is different from the embryological anal canal, and this is why, you can see your kind of cloacogenic type anal cancers. And so your surgical anal canal will be encompassed by your sphincter complex. Many of you told me it was about 3 to 5 centimeters, which is appropriate. I asked about the anal verge because, again, these are terms that we kind of throw around when we're talking about a colonoscopy or an exam, and we're not always familiar with them. The AJCC, this is taken from the NCCN and quoted from the AJCC. So we also talk about, perianal cancers, that zone that's proximate to the anus that, is treated more like skin cancer. And I thought this was an interesting definition, so I put it in so that we could be comfortable with it. So the anal cancers are tumors that develop mucosa that cannot be entirely seen when the buttocks, that should be an R, not an is, are gently pressed. So you could also talk about the transition between the hair-bearing and non-hair-bearing skin, just kind of concepts that you want to have familiarity with. People went through their workup, anoscopy, exam under anesthesia, biopsy. These tumors are largely HPV related. Generally, people knew the common strains, 16, 18, 31, 33. It's given different numbers of the prevalence. I think I would accept anything in the 70 to 95 range. I probably wouldn't really take anything under 70%. Staging, and several of you asked about kind of how important staging is for these. I personally, I think it's worth being familiar with the staging. I doubt that you would be failed on a staging question, unless it impacted treatment and prognosis. So I think if you fail to grasp, an imaging or an exam finding that would change your treatment recommendations, I would have some concerns there. But short of that, I think it's worth being familiar with the staging. And pretty much everyone that I talked to got this right. I wouldn't stress over it excessively. I will point out this is a change from 7th to 8th staging editions. So groidinones used to be N2 and they are now N1A. So again, kind of simple contouring questions. The goal here is not necessarily to have something beautiful, but to be kind of comfortable with the process. It's helpful to talk your way through the anatomy as well. You can. I will say, I think some of the examinees may have been asked, if you see my cursor hovering here, whether these were lymph nodes. This scan was supposed to correlate with the PET here. This is a muscle bundle. It's not a lymph node. So I think I may have confused some of my fellow examiners with that, if anyone was tripped up by that. I put in, these are from the contouring atlas at a roughly similar level. You know, if you're talking through your contours, you probably would want an empty rectum in this. You know, for your SIM, you could use a vaginal dilator. Some people use the vaginal dilator with SIM, which I personally favor. Reduces dose to the vaginal introitus, and that can be helpful. You'd cover, obviously, your inguinal nodes, your external iliac, your internal iliacs, your obturators, your mesorectal nodes. You know, you could either SIM with a full and empty bladder, or at a minimum, you'd want to make sure your primary contour took a little bit of a bite out of the bladder to allow for variability in bladder filling. We would generally treat these patients with a comfortably full bladder, supine, frog-legged, and nobody gave me anything but IMRT. I very much doubt that you would have to explain an old school 3D, you know, Thunderbird type plan on orals. In terms of treatment, I don't think it's wrong to do sequential treatment in that setting, in which case, you know, you probably take your initial volume to 30 to 36. You'd have your mesorectal nodes probably go into 45, and then you'd take your primary to 50 to 55 gray. I probably wouldn't go above 54, 55 gray for this primary. Everyone I talked to did RTOGO 529 style. That's what I do in my practice. I find the SIB plans just a lot more, I think it gives you more control over dose. It's more efficient. It's a better use of your dosimetrist time. In general for these, I would pick kind of one thing that you're comfortable with that's appropriate and know it well, as opposed to sort of spreading yourself too thin, knowing a lot of different options. In general, as long as you have one thing that you're comfortable with, you'll be in good shape. And so for this particular patient, if you're doing 0529, you do 30 fractions, you do 54 to the primary, you do 50-40 to the node because it's under 3 centimeters. And then your elective nodal volume would go to 45. And obviously you go at 1.8 and then subsequent lower dose per fraction there. I did ask about chemo. So my thoughts on chemo. I think you're safest saying 5-FU and mitomycin C. Obviously, there are some studies such as ACT2, which suggest equivalence between cisplatin for mitomycin C. Prior studies, you know, things like 9811 were confounded by the use of neoadjuvant chemotherapy. If you do choose to use cisplatin, and that's your practice and what your institution does, I would be prepared to defend that slightly, but I don't think you fail for that as long as you understand the rationale and the alternatives. I don't know that you have to know all the doses in detail, but it's probably worth being familiar with them. And there are slight institutional variabilities. One person gave me concurrent capecitabine, which is not unreasonable. But typically we do infusional 5-FU, days 1 and 29, there's different schedules for your bolus mitomycin C. Some people omit the second mitomycin C, but this is how 0529 was done. And again, I would pick one simple thing that you're comfortable with and know it well. Follow-up. So I did ask a couple of questions here. Asked about long-term side effects and quality of life issues, and I was looking for a couple of things. I was looking for the range of bowel symptoms, including proctitis or incontinence. I was looking for bladder symptoms, including cystitis. I was looking for a range of sexual dysfunction questions, including vaginal stenosis, dyspareunia, dryness, menopause if the patient were not already postmenopausal. One examinee did tell me, well, I guess we don't worry about sexual function because the patient is 65, which I would strongly discourage you from saying on orals. I think your examiners will frown on that. And again, remember, for a 65-year-old woman, you'd want to think about bony complications of treatment, so sacral insufficiency fractures or femoral head necrosis. Let me, go into the chat real quick here. Any questions in the chat so far about that? to switch windows. Okay. Second case. So similar, but we moved into a rectal cancer. So now we had a younger patient. This was a low to mid rectal cancer. In this case, I was looking for a discussion of both fertility and hormonal function. And your options there obviously would include things like egg harvesting, ovarian transposition. I'd be somewhat familiar with success rates of ovarian transposition, which in our practice are about 50%. And probably also be cognizant of the fact that if you're giving full dose pelvic radiation, you're probably going to have some uterine dysfunction. And if you are talking about post-treatment fertility, your safest option might be, egg harvesting and consideration of a surrogate or something like that. So I was hoping for some discussion of those factors as part of the workup. Again, I think you can present kind of whatever staging workup you're comfortable with. None of my examinees gave me EUS for T staging. This is I circled it on here. This is a T3 rectal tumor on EUS. I think pretty much everyone did rectal MRI, which certainly is our practice. I prefer it. I feel like you get a better nodal evaluation. I find it much easier to contour my primary when I confuse my MRI. And it gives you probably a better evaluation of whether your CRM is threatened or not. I would be comfortable with at least some of the general parameters how to do it. A rectal MRI is a special protocol. Does require an adequate magnet. It requires special sequences, including small field of view encompassing the axial, sagittal, and coronal planes. It does not require IV contrast. Several of you gave me IV contrast, but my institution, we do not do contrast for these. And your go-to sequences are typically your T2 small field of view images, which is what I gave you if you asked for that. I circled here basically the tumor, extending into the mesorectal fat. The arrows, through some people, they were supposed to indicate the clear flat fat plane between the tumor and the uterus. I think some people thought the arrows indicated that it was invading the uterus, for which I apologize. There also were a couple, this is hard to tell just on a single sequence, but there were a couple enlarged mesorectal nodes as well. I asked about fields. So I gave you my first attempt at drawing my fields here, just so that you could understand how my fields are not very good either. I think in hindsight, I probably would have gone up and caught the femoral heads a little bit better. I have my tumor in there, so you'd give 3 to 5 centimeters below your tumor. Short of that, you go to the inferior aspect of obturator foramens. You give a centimeter or 2 on the pelvic brim. It's hard to see your L5-S1 interspace. You could also tell me you'd contour your internal iliacs up until you see where they joined the common iliacs and plan off of that, which would not be unreasonable. For your laterals, you typically want to include your sacrum. It's easier to see your L5-S1 interspace here. You do, again, you could tell me you contour this and sort it out, but for T3 tumor, which this was, you wouldn't have to go to the anterior aspect of pubic symphysis. You'd go to the posterior aspect. And again, a lot of your orals examiners are going to be, by definition, older than you are. Old people like asking questions about things they do that you don't do anymore. They're all used to, the 2D planning era, or at least, checking films and stuff like that in that setting. And so sometimes it throws you just to have to look at a DRR. So here's your pubic symphysis, that little bird beak thing on it. So how do you treat? Again, I did not think anyone should fail for long course chemoradiation, surgery, adjuvant chemotherapy. I think that is a suboptimal choice, and I do think you should be aware of alternative options, including the options of total neoadjuvant therapy and short course regimen. And so I prompted all of our examinees to give me this. I would be familiar with the Rapido regimen, which was published in the Lancet Oncology in 2021. And I have the schema for both Rapido and Prodigy below. Rapido was a comparison of long-course chemoradiation versus short-course pelvic radiation, followed by chemotherapy, followed by surgery, which was the experimental arm. The Prodigy arm is even more intensified chemotherapy, standard chemoradiation, and surgery with a little bit on the back end. So there's a range of TNT regimens out there, but you should at least be familiar with an option there. Sorry, I lost my train of thought. How to deliver short course pelvic radiation. If you wanted to be kind of familiar with the outcomes here, they both had pretty good CR rates, so much higher. These are the experimental arms for both trial. And again, remember the outcomes here. We did not see survival differences, although we had a trend for Prodigy. But there was a significant benefit in distant metastasis-free survival, which is a pretty big deal in rectal cancer because our local control rates are probably pushing the limits of what we can reasonably achieve, and we're more worried about distant failure. And if you look at your NCCN guidelines for T3N positive patients, T3N any or node positive patients, TNT is preferred. I did ask about contraindications for short course pelvic radiation. That was more of a sort of show me your thought process question. But to me, maybe an ultra-low tumor where you had to treat the groin, maybe a threatened CRM, although if you look at the PCR rates, for Rapido, they're pretty darn good. In our practice, we have some concern about patients with positive lateral pelvic sidewall nodes, which are not typically surgically resected, and we boost those to definitive doses with long course. But I think you could defend doing short course on essentially any patient in this. And I put in my slide deck, these are constraints that you can use for your short course patients if needed. So the first two cases took a fair amount of time for most of my examinees. The third case, I was trying to focus a little bit more on evaluation of a dose volume histogram and making sure everyone was comfortable with that. So this was a GE junction esophageal adenocarcinoma with the PET scan indicated below. For this, I considered, either an RTOG style neoadjuvant regimen to 50.4 gray, typically with a sequential boost after 45 gray, or the cross trial, 4140 gray. I think if you do carbotaxel in your practice, I would say carbotaxel. It's fine to do carbotaxel with 5040. I think it's also appropriate to do cis-5FU or FOLFOX. And in all likelihood, you would do 5040 in that setting. For this dose volume histogram, I was looking for people to push for lower heart and lung doses here. So this heart, if you look at the V40, the V40 is 70+%, which is not acceptable. If you look at the total lung, the V20 is good, it's under 20. The V10 is about 65%, and the V5 is about 80%. And although these are, perhaps lesser parameters, I would try to be familiar with all of them. I gave the following DVH, which I will say is a DVH I signed off on. This patient actually was treated on RTOG 1010, one of the old RTOG trials, and met RTOG 1010 criteria. But I do think, like several people told me, this heart dose is probably higher than it should be. I asked for techniques to lower the heart dose, and people gave me a range of appropriate techniques, switching to IMRT, consideration of protons, 4D CT, deep inspiration breath hold. There were a couple of people who started with 50 gray, and I asked and asked and asked, and I was fishing for dropping to 41 if you couldn't meet your heart constraints. So I would be ready to drop to a lower appropriate dose for a neoadjuvant patient if you're having trouble meeting your heart or other constraints. And I did ask about different surgical techniques. I would broadly be familiar with those. I think any of them are acceptable. You could do, an Ivor-Lewis, a transthoracic esophagectomy, a transhiatal esophagectomy, but just be roughly familiar with what your surgeons do. I did put, a set of DVH parameters in if you don't have something that you're already typically using. I do personally look at V20, 10, and 5s, and I would have those in as targets. Those of you who do a fair amount of this know that we often struggle to meet at least the V5 constraint. I personally weight the mean dose most heavily and generally get quite a bit below 20, but I would consider all of these. And here are just NCCN heart dose guidelines as well. I will also mention, the Checkmate 577 study. I think this is more kind of bonus territory, but, there is data showing a rather impressive benefit to disease-free survival. This was New England Journal of Medicine, came out right before orals last year, but I think it's disseminated at this point. It's actually made its way into NCCN guidelines. So for patients who fail to have a path CR to neoadjuvant chemoradiation, there is a potential benefit to nivolumab. The fourth case was a pancreatic cancer case. I was looking for a couple of things here. You want to stent this patient. Obviously, you don't want to get too far ahead of yourself until you've got the bile ducts opened up again. Imaging, so it's always a little bit tricky. You should be able to appreciate that this is an arterial sequence because the aorta clearly is lighting up here. This is a celiac, although you could potentially confuse it for the SMA. And then we have your typical kind of hypoenhancing pancreatic head tumor indicated by the second arrow. Panc is a mess right now. I would, generally start with chemotherapy for either unresectable or borderline resectable patients. I would still be familiar with old school contouring. So, this is the RTOG contouring atlas, and typically this is something I would do for, for a post-op patient with, with a positive margin or something like that. I also think at a certain point you could be asked, after delivery of chemotherapy to do either SBRT or definitive chemoradiation to an unresectable or borderline unresectable patient. But those will be fairly probably select circumstances. And then the final case was in essentially, I feel like bonus territory. This MRI probably in the real world would get surgically resected. You had a medically inoperable patient. In my practice, the IR guys would get a hold of this, and this would be microwaved or possibly combo microwave, TACE. But I did ask for criteria for radiation eligibility. So for SBRT, you would look at your child Pew score, either an A or a favorable B. I don't think you have to be able to score a child Pew patient, but I would be at least able to think of the relevant clinical parameters. 3 of them are laboratory, 2 are based on history. So those would be your Billy, your PTINR, your albumin, and then ascites or hepatic encephalopathy. And then there's a range of different doses and fractionations and constraints that are out there. I personally like the Princess Margaret constraints, which I just put in there. Your D800 under 15 gray. So hopefully this was a good experience for everyone. I felt like at least the examinees I had did I think, fairly well with it. And I am happy to answer any questions people have. I had the chat open and I just closed it. So let me see what I need to do to open the chat again. June, do you see the chat?
Yes, I do, but there's no question on the chat. So I will share all the site leads, email addresses later via email. Oh, yeah, there is one question actually. Should we know the pre-opaque regimen?
Do you use it in your practice? So, I would do what you're comfortable with. If you're comfortable with, and the pre-opaque was, that was a hypofractionated regimen, if I'm remembering correctly, wasn't it? If you don't routinely do that, I would probably just do 50-40. Do your 45 gray to a larger volume and tone down. Or if you can justify it, for node negative, borderline resectable, both in my practice and for most of our trials at this point. So we've participated in a range of studies, including some of the Alliance, neoadjuvant SBRT studies and so on. We also do some pharma studies looking at novel combinations of SBRT and radiosensitizing agents. In that setting, we're largely treating gross disease plus margin. I think either of those is acceptable. Elective nodal coverage for esophagus on oral boards. So I feel like there's a couple of different questions in that question. So for distal esophageal cancer, I do in my practice treat the celiac nodes. And I treat them because, number one, they were treated in many of the cooperative group trials that we participated, including RTOG 1010. I find that I can generally encompass them without exceeding my tolerance volumes, although I will caution you for your neoadjuvant patients to be careful about your stomach doses in that setting because you are kind of dragging your volumes inferiorly. And so I would kind of watch my stomach doses there. And, if you look at the, the AJCC staging guidelines and some of the surgical data, celiac nodes are technically local regional and therefore curable, even looking at some of the surgical series. And so I do typically include them for distal esophagus. For upper esophageal cancers, especially squames, so, if you're above the carina, I would typically include a superclav field and perhaps a very kind of slightly expanded field of the upper mediastinal nodes as well. But I think there's a little bit of variability in what people do there. There is a fairly nice contouring paper that I believe Dr. Jen Wo published a few years back, which I think would steer you well if you need a reference there.
If there's no other questions, I think we can take a break now. So last chance to ask questions. Anyone?
All right.
All right. Thank you so much, Dr. Lominska. And
Good
enjoy
luck,
the game.
everyone. Yes. Thanks, June. Bye-bye.
All right. And please come back